Hi, good morning. I'm Dr. Neeraj Manikat. Today we will deep dive into one of the classical diagnostic dilemmas in reproductive endocrinology, differentiating PCOD from non-classic 21-hydroxylase deficiency. As clinicians, we frequently encounter patients presenting with hirsutism, acne, and irregular menses. While PCOD is the default diagnosis in most, failing to screen for non-classical 21-hydroxylase deficiency is a significant clinical oversight. The stakes are high, the treatments differ, the genetic implications for offspring are also distinct. The underlying pathophysiology, although the symptoms are overlapping, stems from two very different organ systems. Let's see the pathophysiological divergence. To understand the difference, we must look at the source of androgen excess. In PCOD, this is primarily a syndrome of ovarian androgen excess, along with insulin resistance. The vicious cycles involve high LH pulses, which stimulate the ovarian theca cells to produce androgens, further exacerbated by hyperinsulinemia, which inhibits the sex binding globulin. In non-classical adrenal hyperplasia, it's a purely adrenal enzymatic defect, an autosomal recessive condition where a mutation of CYP21A2 gene leads to partial deficiency of 21-hydroxylase. So unlike the classical salt wasting variant in infants, 20 to 50% of the enzyme activity is there. This is enough to prevent adrenal crisis, but not enough to prevent backup of precursors. So when 21-hydroxylase is sluggish, the pathway of cortisol is impaired. Through negative feedback, pituitary pumps in ACTH to compensate. This ACTH stunts the steroid precursors into the androgen pathway, specifically elevating 17-hydroxyprogesterone and androstenedione. Now, when to suspect NCH over PCOD? The clinical presentation alone is often insufficient as both the conditions have a hyperandrogenic phenotype. So, certain red flags should steer you towards an adrenal investigation and atypical congenital adrenal hyperplasia. Early adrenarche, a history of pubic hair or body odor before the age of 8. A family history is highly prevalent in specific ethnic groups like Jews, Hispanics, and Mediterranean population. And the severity of hyperandrogenism. While PCOD can cause severe hirsutism, very rapid onset of virilization like clitoromegaly and voice deepening should always trigger a search for adrenal tumors or non-classical adrenal hyperplasia. Short stature, unlike PCOD, which are often average or tall height, this non-classical adrenal hyperplasia have an accelerated childhood growth, followed by early epiphyseal closure, leading to shorter than expected adult height. So you cannot differentiate these two based on ultrasound showing the classical polycystic ovaries, because high adrenal androgens in NCH can actually induce a polycystic ovarian morphology on ultrasound, fulfilling the Rotterdam criteria for PCOS, even though the cause is adrenal. So the gold standard is screening for 17-hydroxyprogesterone. This is the first step. In early morning, 8 a.m., 17-hydroxyprogesterone is measured during the follicular phase. A value of below 200 is normal, and non-classical is highly unlikely. Proceed with the PCOD workup. The gray zone is between 200 to 1000 nanogram per deciliter, which is highly suggestive but need further test, while a value of over 1000 is almost diagnostic of non-classical adrenal hyperplasia. So in the gray zone, you can do the ACTH stimulation test. Administer 250 micrograms of synthetic cosintropin and measure 17-hydroxyprogesterone 60 minutes later. The PCOD patients often has mild elevation, but the values always stay below 1000 nanogram, while non-classical adrenal hyperplasia have got a hyper response, and typically it shoots to above 1000 to 1500 nanogram. Now, clinical features we can summarize. Usually in non-classical adrenal hyperplasia, the final height is much less than expected, and the patient is usually lean, and features of central obesity are absent. So also features of insulin resistance are also absent. Although morphologically, imaging wise, both will show polycystic ovaries. These can help you in differentiate. Now coming to the management nuances. Why does this distinction matter in managing PCOD? Is often managed by lifestyle modification of weight loss, using insulin sensitizers like metformin and oral contraceptive pill to suppress ovarian androgens. While non-classical adrenal hyperplasia management may require low-dose glucocorticoids like dexamethasone or hydrocortisone. This is intended to suppress the ACTH drive. This is especially crucial if the patient is seeking pregnancy, as it normalizes the hormonal environment more effectively than metformin in this specific cause. And of course, genetic counseling is almost always a must in non-classical variants, as offspring can have, if the partner is a carrier for a classical mutation, the child having a full-blown classical adrenal hyperplasia is very high and can result in infantile death.